to discuss a very complementary topic to the previous talks, and these are my disclosures. Has nothing to do with this presentation, and we will talk about the role of MRI in screening prostate cancer and their shortcomings, and see whether there is a role in biomarkers to cover this gap, and then see if there's a shared decision-making procedure that can help to identify these MRI-invisible lesions, including some of them are even not detected by standard trust biopsies. So you know the standard problems with PSA, DRE screening, overdiagnosis, over treatment, and the standard biopsies are subjected to sampling errors. The MRI has been now adapted for screening, and of course, MR-targeted biopsies detect higher percentage of clinically significant cancer. There are certain advantages. However, one of the questionable advantages they outline is can spare biopsies for men without any identifiable lesions. Is that a good idea? The problem is the negative predictive value of the MRI, which depend on the disease prevalence. Once you adjusted it to the disease prevalence, it may not be as high as 90%. So the negative pre-biopsy MRI is not a precursor to spare systematic biopsies on biopsy-naive patients specifically, not just repeat biopsy, the biopsy-naive patient. We'll give you some examples. Now, can we use biomarkers to identify some of these patients? Yes, definitely. There are a whole bunch of biomarkers available in this space: 5, 4K score, PCA3, select MDX, etc. And a PCP can order most of these tests. And in this cohort, patients had standard trust biopsies before, and then they also had one or more biomarkers tested to see if they have clinically significant prostate cancer. Subsequently, they proceeded to have multiparametric MRI. I'll show you why. And then a subset of this whole cohort underwent a transperineal mapping biopsy. And we have a very strict protocol at UC Anschutz, which Dr. Crawford used. We use 5 millimeter grid biopsies, and which gives you the most accurate detection of clinically significant cancers. And you can put the histopathology into a picture like this, and we can actually plan on focal therapy and variety of other treatments. Now, here is the patient cohort. As you can see, the highlighted patients all had multiple biopsies, trust biopsies, even saturation biopsies. They were all negative. Another 3 patients had minimal findings, inconclusive. It was a very small focus of grade 4 cancer, grade group 4 cancer. So the question is, what do we have to do with these patients? So that's when we use biomarkers, and I'll show you here. The focus has to be on the MRI first, and then the final pathology here. The first patient, MRI negative, he had grade group 5 cancer. The second patient had a PIRAD 5 lesion, 1 lesion on the left-hand side, which is a true positive, again, grade group 5 cancer. And this PIRAD 2 lesion is, quite inconclusive. And he also had negative findings. The PIRAD 4 is a false positive here. And these biomarkers, again, a sort of a mixed bag. The one I'll show you, give a summary of these, how they performed. The phi actually seems to detect most of these patients, and then phi density. And as you can see, the transperineal mapping biopsy diagnosed all of these patients accurately. And here is the first example. And the first patient had 5 lesions in the prostate. Every one of them were MRI invisible, and had 4 trust biopsies, all negative. He had only 1 biomarker test, which is negative. Multiparametric MRI was also negative, but the final pathology was grade group 5. So this is one example. The second example, this is a very interesting case. Again, multiple biomarkers were positive, and he's the one who has 1 PIRAD 5 lesion on the left-hand side, but you can see his cancer is quite extensive. Obviously, if you do MR-targeted biopsies, you have to do some systematic biopsies as well. And they have, again, grade group 5 cancer, and then about 7 lesions within the prostate that we identified. Third patient is a very interesting character. He had rising PSA over a 6-year period. Again, 5 trust biopsies, they were all negative. And again, he was indicated by biomarkers to have high-grade cancer, and MRI negative. And again, you can see the grade group 2 cancer here, and he has not decided on any treatment. And the last patient I will show you here is the one with the false positive pyrite 4 lesion on the right, on the left-hand side, and he also had he had a positive trust biopsy finding, which is a small focus of grade group 2 cancer, and he opted for cryotherapy. So here's a summary of all the biomarkers that used. The 5 did the best in this group, and the PSA density on 5 out of 6 patients indicated to biopsy these patients. So if the MRI is negative, the prostate specific density and antigen density is positive, indicating that they have to have biopsy. The problem is the trust biopsies doesn't reach to the anterior portion of the prostate. Most of these lesions were anteriorly located. So the trust biopsy findings were negative. So it is sort of like a dilemma. Now, what do? Your MRI is negative, your biomarkers were positive, and you're going to do a biopsy, and then you have to target the anterior portion. So the approach we would propose, or at least we'd like to see, the PCPs order most of the PSA, or more than 90%, and so they are better suited to run these biomarkers. So if urologists find a patient with elevated PSA, he needs to run 1 or more biomarkers, and if 1 or more biomarkers is positive, then refer to a urologist. But the challenge is these PCPs need guidelines. What is the PSA cutoff? How do you do these things? Is it 1.5, 4? So you have to give clear guidelines to your PCPs. So the takeaway message: yes, we need to diagnose these patients. They are very important with the clinically significant cancer. But the problem is the clinical pathological features of these lesions make it very difficult. You saw multiple trust biopsies, even saturation biopsies did not pick up these patients. And to add to that confusion, your MRIs are negative, and the disease is multifocal. Just because you saw one pyrite lesion, of pyrite 5 lesion, doesn't mean there is nothing going on elsewhere in the prostate. As you saw, the disease was all over the place. The NPV of the MRI is prevalence dependent. So once you adjusted it to the prevalence, it is not going to be 90%. So you cannot rule out a patient, especially biopsy-naive patient. He has a negative MRI and we can spare him biopsies. The PSA biomarkers offer an alternative pathway to identify some of these patients. Again, they are also subjected to false positives and false negatives. Currently, transperineal mapping biopsy is the only method for accurately staging these patients. That is the 5 millimeter grid biopsy. So if nothing else works out, I would recommend, that is probably the path for you to take. Again, the shared decision-making procedure that link the PCP and the urologist will, basically give us a pathway to identify these candidates and provide them customized therapy. Thank you very much.
Priya, thank you.
One question on that?
Yeah.
Thanks, sorry to interrupt. With the apical lesions, and do you find that lesions are more difficult to identify or grade as a PIRADS 3, 4, or 5 if it's an apical lesion? Or is there something about being able to have that lesion surrounded by other prostate tissue that makes it easier to grade?
Is that one of the patients you are referring to?
Oh no, you just mentioned that in all these patients that have
anterior lesions, not anterior.
Anterior, not apical.
Not
okay,
apical. I mean, apical lesions you can actually hit. Even if it is anterior located, you can hit them. But those are more close to the anterior horn portion of the prostate, and as you can see, the standard trust biopsy does not reach that far. The needle is only about 20 millimeters long, and it doesn't go that. That was the whole issue.
Especially if it's over the urethra.
Yeah.
Thank you very much.